Hey everyone, it is Professor Lee, and this is the Key Points lecture for Introduction to CPT Coding. So we begin with some of the basics. The CPT and HCPCS, or HCPCS, procedure coding systems are the procedure coding systems that are used by physicians, non-physician providers, so things like nurse practitioners, physician's assistants, think people like that, and also outpatient facilities to bill for services. So providers establish a fee for each procedure code, which then becomes the basis of reimbursement calculations. One important thing to remember is that we cannot have a procedure code without a correlating diagnosis code. And those diagnosis codes, which you learn about during the ICD-10 course or ICD-10 CM section of this course, if you're taking my Medic 238 course at Contra Costa, the diagnosis codes provide the medical justification for the services. For CPT coding, we are coding the services. So the P in CPT stands for procedural, and so that is what we are coding in the CPT system, are the procedures, the things that have been done to patients, the services that have been provided to them. The CPT coding has a significant impact on reimbursement because the fees are attached to CPT codes. In order to code accurately, we must match procedures to those diagnoses and then code for the appropriate level of service, adhere to reimbursement edits, and also understand how physicians and outpatient hospitals are reimbursed. So we work through all of those things in this course. The contents of the CPT manual are something that you definitely need to be familiar with, and we're going to get a little bit more in depth with the contents in these other bullets here. But generally, you need to be familiar with the organization of the CPT manual as well as its coding guidelines, instructional notes, and conventions as well. One other thing to note about the manual is that it is updated every year, and every year those changes take effect January 1st. So if you're wondering why we have CPT coding or what the purpose of CPT coding is, we use CPT coding because it is required by the Health Insurance Portability and Accountability Act, which is HIPAA. That HIPAA Act mandates the use of CPT for all covered entities that handle electronic claims related to outpatient healthcare services. The AMA, or American Medical Association, developed and published the very first edition of the CPT manual in 1966, the year that Medicare and Medicaid programs were implemented. And since then, it's been responsible for CPT codes. In 1983, the federal government adopted CPT as part of its Healthcare Common Procedure Coding System, more commonly known as HCPCS, and later required it to be used to report services that are billed to Medicare Part B and Medicaid as well. So CPT codes are also sometimes called Level 1 HCPCS codes for this reason. I think I skipped over this middle bullet, and so let me go back to the code structure really quick. The code structure for CPT codes is 5 digits. There's no decimal point anywhere in those digits. They are alphanumeric, depending on which system you're coding from. Also, there is no definition per digit. So if you've taken my PCS coding course, then you know that each digit in the code structure means something. It identifies a specific element of the procedure. That is not true with CPT codes. They are just 5 characters, alphanumeric, and no decimal points, and they are descriptions that report outpatient medical services and procedures. Okay, so we're going to go down and begin with information about the index. So the introduction of the manual provides a table of contents by page number. It also includes instructions for use of the code book, and then depending on which edition you have of the manual, sometimes there'll be other valuable information at the front of the book as well. The index is the first section, major section of the manual. It is the the section that you use to locate the preliminary codes, and we do that by determining the main term, modifying terms, and codes or code ranges. So the CPT index classifies main terms in 4 ways that you need to know about. The first is the procedure or service name. The second is by organ or anatomic site. The third is by condition, and then the fourth is by synonym, eponym, or abbreviation. So once you've located the main term, reviewed the modifying terms located under the main term, and any instructional notes, then you will flip to the tabular list. So preliminary codes are printed immediately to the right of the modifying term in the index, but all codes have to be verified in the tabular list. You cannot select a code based only on the information in the index. I cannot stress to you how important that is. The tabular list provides a numerical listing of all CPT codes that are divided into 3 categories. So there's category 1, which composes the bulk of the CPT. Category 1 codes are 5 digits in length. They are numbered beginning at 00100, and they go all the way to 99607. The Category 1 codes are they describe widely used services and procedures that have been approved by the FDA, and these are considered to be permanent codes. The next category is Category 2. Those codes are optional codes that are used to collect and track data for performance measurement, and those codes consist of 4 numbers, not 5, followed by the letter F. So for example, if you were coding anginal symptoms and level of activity assessed, then the code would be 1002F. So you know that Category 2 codes always have an F as the last digit. Category 3 codes are codes that are they're temporary codes used for data collection and for tracking the use of emerging technology, services, and procedures. And those also consist of 4 numbers, however, they are followed by the letter T at the end. So for example, 0163T describes a procedure involving a total disc arthroplasty. If a Category 3 code is available, then you should report that instead of a Category 1 code. So it's important to remember that tip about Category 3 codes. So again, I just want to stress that all codes must be verified in the tabular list once you have identified them in the index. And we do that to ensure that the description accurately represents the service provided. So once you have located the preliminary code in the tabular list, so you found it in the index, you've now found it in the tabular list, you need to begin interpreting these tabular list conventions. Some of those include things like a semicolon. A semicolon in a code description is used to conserve space and to avoid having to repeat common terminology. So what the semicolon does is it separates a common portion of the procedure descriptor that applies to the codes that follow from the unique descriptor that applies only to that code number. So it gives you a little bit more information, but doesn't spell everything out. You need to go up and check for that information elsewhere. Narrative instructions also appear in several locations, and those include things like guidelines, special instructions, and instructional notes. We have symbols. I have uploaded a symbol chart in the Learning Objectives page for you. The symbols alert the user to certain circumstances that can affect the use or interpretation of the code. So it's very important that you understand all of those symbols. They are also located in the front of the manual, and so in the professional or expert editions, they are also often located along the bottom edge of the page on each page. So once you have figured out your code, you have verified it in the tabular list, the next thing to do is to make sure that you are selecting the code with the highest level of specificity. You want to be as specific as possible while you are selecting the code. You want to review that code for appropriate edits, such as any bundling issues, add-on codes, and then also notate the quantity. Lastly, you want to append the modifiers, so add the modifiers to that code if they are necessary, and then you can assign your code. So those are the steps for using the index in Tabular List. But to get there, you need to learn a little bit about abstracting. So we're going to go back up here to the top. Diagnosis codes are required to explain the reason for the encounter and or the reason that services were provided. So even though we are coding for procedures, it is again important that we have a diagnosis code to base those procedures off of. So you, as the coder, must be certain to abstract and assign at least one ICD-10-CM diagnosis code for each procedure or service that is billed. The process of matching each of those CPT codes that you have selected with one or more diagnosis codes is a process called code linkage. So kind of keep that in mind. The index lists, sorry, I had a phone call coming in. The index lists procedures and services in the CPT manual alphabetically by main term and modifying terms that aid in locating the most appropriate code or range of codes. So modifying terms in the index entries are, modifying terms are index entries that add further detail to the main term. So they tell you a little bit more about that main term that you found in the index. There's a difference between modifying terms and modifiers. Modifiers are two-character suffixes that are appended to those Category 1 codes, like I just spoke about when we were going through the tabular list information a few minutes ago. Those modifiers further explain the service that was provided. So there are a whole bunch of examples of modifying terms and modifiers that are provided throughout the chapters in this CPT section of the textbook, so definitely read those little help boxes that are along the sides of the pages or and set into the pages so that you can get some clear examples of the difference between modifying terms and modifiers. Okay, so once you understand those things, then we have 3 basic steps for abstracting information. Step 1 of abstracting is to identify the primary service or procedure. First, you're going to look for the chief complaint or the reason for the visit, which usually provides an indication of the services that may have been provided during that visit. You want to identify the primary procedure or the main service provided during the encounter. It's very common for the E&M code to be the only service that was provided, and an E&M code includes the ongoing evaluation and management of a patient's care, specifically things like taking a patient's history, conducting a physical examination, and performing the medical decision-making required to create a plan of care. Now we're going to dive deep into E&M codes in a couple of chapters, so don't worry about understanding that too much right now. Just keep in mind that sometimes the E&M code is the only CPT code that we have, and that's okay. Step 2 of abstracting is to identify secondary services or procedures. So secondary procedures are any services that are documented in the medical record in addition to the primary procedure. At the time of abstracting, you don't necessarily need to know whether an additional service or procedure can be coded because it often depends on how the specific code is defined in the tabular list. So keep that in mind. The last step, or step 3 of abstracting, is to identify the quantity of each service. So although you might not be responsible for preparing the claim, you are responsible for identifying the quantity for each code because quantity is reported differently for different codes. So for services that can be repeated multiple times during one operative session, such as like a removal of lesions, the quantity reported with the code is going to vary based on the code definition. For services that are based on time, identifying the number of minutes spent providing the service, then you want to convert those to the unit of time required by the code description. And I have a whole nother section on the units of time and coding when we get to the E&M chapter in a couple of weeks. Lastly, you want to abstract only services provided during the encounter being coded. So we do not abstract information or provide codes for services that were previously provided or services that may be planned for the future. The last set of key points you should know about are the appendices in the back of the CPT manual. Now there are several in the back of the manual. I think last time I checked they ran all the way to like F. Hang on, let me grab the book and I will tell you. M, I'm looking. P. They go all the way to Appendix P in the professional manual that I have. The three appendices that you will reference the most often are A, B, and C, which is probably why they're up at the front of the stack of appendices that are in the back of the book. So Appendix A we reference for modifier information. Appendix B we reference for code changes. So those include deleted codes, replaced codes, modified codes, anything that may have been updated since the last publication of the manual. And then Appendix C provides extra information on the E&M guidelines. And so it is, oops, I just dropped my manual if you heard that big boom. It is extra details about coding some of the E&M guidelines, coding in accordance with some of the E&M guidelines. So you definitely want to make yourself familiar with Appendix A, B, and C because you will utilize those frequently throughout this course. All right, everyone, that is the key points for Introduction to CPT Coding. Be sure you're reading your textbook chapters. Be sure you are watching the other lectures that I posted, and reach out if you have any questions. Take care, everyone.